Thank you. Thanks a lot, Dr. Alaska, for your nice introduction. I hope you can see and hear me loud. So I thank Sanofi for this invitation as well. And I'm delighted to be this evening, at least virtually, with you to share the French experience in the management of acquired thrombotic thrombocytopenic purpura, now in the area of targeted therapies, and especially with the use of caplacizumab. So, as you know, TTP is a specific form of thrombotic microangiopathy, which is characterized by the association of a microangiopathic hemolytic anemia with a profound peripheral thrombocytopenia and organ failure of variable severity that leads to the death of the patient in the absence of adapted treatment. And you have in this disease a specific biomarker, which is a severe deficiency in the enzyme ADAMTS13, which is involved in the cleavage of the high molecular weight von Willebrand factor multimers. According to the mechanism of ADAMTS13 deficiency, you can identify two forms of the disease: a congenital form, which results from biallelic mutations of the encoding gene, or an autoimmune acquired form of the disease that mostly occurs in women, which is again spontaneously fatal, and which incidence is quite low, and around 2 to 3 cases per million inhabitants per year, which in France represents a little bit more than 120 new cases per year. So this evening, I will mostly focus on the autoimmune form of TTP, which is the most common one. And this is the form that you may meet the most in your current practice. So this is the pathophysiology of the disease that you need to have in mind to understand the treatment of the disease. So you have in this form of the disease autoantibodies directed against ADAMTS13 that alter its activity. And as a result, the substrate of the enzyme, the high molecular weight VWF multimers, accumulate upstream. And these high molecular weight VWF multimers are hyperadhesive towards platelets. So this leads in microvasculature to microthrombi in most organs, and in the end to the death of the patient through a multi-organ failure picture. So if you have that in mind, so you understand easily that in this disease, patients lack from ADAMTS13, so you have to bring ADAMTS13 and replenish ADAMTS13 levels. And through this, you firstly saturate anti-ADAMTS13 antibodies, and then you also cleave the large VWF multimers. And this can be achieved with the use of plasma exchange that allows to bring to the patient very large volumes of plasma that contain exogenous ADAMTS13. Secondly, you have to target the immune system to block the formation of antibodies against ADAMTS13. So here you can be more or less selective, and you might target B cells, most of all, with the use of rituximab, but also T cells with the use of cyclosporine. And more recently, there was some attempt to target plasma cells with compounds usually used in patients with myeloma. And lastly, there was an attempt to address this specific pathologic interaction between VWF and platelets with the use of caplacizumab that allows to inhibit this pathologic interaction. So I will come back on that later. So before starting treatment in this disease, you need, of course, to be sure about the diagnosis of TTP, and for that, you need to have at least an idea about how is ADAMTS13 activity. And as you know, throughout the world, it's not so easy to have atorvastatin activity in emergency in real time. And in most countries, and even within a country, in most centers involved in the management of such patients, atorvastatin is typically available only after some days. And in France, for example, typically one needs 3 to 5 days before having the result of atorvastatin activity. On the other hand, you need to start this treatment in the patients, which is now a specific treatment, as soon as possible in the hours after the clinical diagnosis. So you need a marker to anticipate atorvastatin activity. And thereby, clinical scores have been developed to reach such goal. So far, there are two scores that are available, the French score and the plasmic score for the US colleagues. So the French score is the most popular one, as it has been used in international clinical trials, and it will be soon used in the forthcoming international trial addressing the treatment of patients without PEGs. I will try to say a word about that later. So keep in mind that those two scores tell the same story, which is that in a patient with features of thrombotic microangiopathy and without any associated condition, so in these patients, when you have a severe thrombocytopenia below 30,000 and a mild or absent renal involvement as defined by a creatinine level below 2.26 milligram per deciliter, you have in this patient, in virtually all cases, a severe atorvastatin deficiency. And again, this score, especially the French score, has been used in the Titan and Hercules trials that have evaluated caplacizumab. So this is the historical treatment of autoimmune TTP that has been set up in the early 90s. This treatment consists in daily plasma exchange in association with steroids in emergency until remission. So this has been the core treatment of TTP for years, and with the systematic use of this regimen, the prognosis of the disease was outstandingly improved. Before the systematic use of this regimen, almost all patients died from the disease, whereas on the opposite, with this regimen, many patients, up to 85%, can now recover from their disease. The second step in the story of TTP treatment was the association to this core treatment of rituximab. So rituximab allows to deplete patients from the B cells, and rituximab was in this disease first used as a salvage therapy in patients who did not respond so well with plasma exchange only. And then, given the positive results, it has been used frontline. So clearly, rituximab allowed to prevent in this disease slow responses to plasma exchange. So you can see in the left part of the slide that up to 23% of patients could be treated more than 3 to 4 weeks with a daily plasma exchange until reaching complete remission. So with now the use of rituximab, we could limit the duration of daily plasma exchange, and now it's very rare that you need to perform daily plasma exchange beyond 2 to 3 weeks. However, keep in mind that rituximab is not efficient in real time, immediately. And as you can see in the picture, you have to wait for up to 2 weeks before rituximab is efficient. So in other words, between the first infusion of rituximab and the durable platelet count recovery that reflects that the patient is cured, you have to wait on average 2 weeks. And during these 2 weeks, everything can still occur, including death or refractoriness or exacerbations. So there was a need to protect patients on this window of time until rituximab is efficient. The last point regarding the use of rituximab in this disease is that rituximab is able to remarkably protect patients from relapses that frequently occur in the weeks or months that follow the recovery of the disease. You can see in this picture that the dotted curve reflects historical patients that did not receive rituximab frontline. And you can see that despite clinical recovery, in the weeks or months that follow clinical recovery, these patients relapse in up to 50% of cases after some years. On the opposite, patients who receive systematically rituximab frontline along with plasma exchange and steroids do not relapse for 12 to 18 months. And we could understand how this occurs. It is simply because even if patients recover clinically from TTP, many of them remain with an undetectable ADAM13 activity. Up to 40% of patients remain with an undetectable ADAM13 activity after the acute phase, and 40% have also a mild decrease in ADAM13 activity that reflects the presence of antibodies against the enzyme. So in total, 80% of patients have a mild or severely decreased ADAM13 activity after the acute phase. And of course, these patients are prone to relapse. So this is a very important observation that led to strongly recommend the use of rituximab frontline in this disease in the last ISTH recommendations for the treatment of TTP. Third part of the treatment story of TTP, the development of caplacizumab. Caplacizumab is a small antibody directed to the A1 domain of VWF. So more in detail, caplacizumab consists in two heavy chain variable domains that are directed to the A1 domain of VWF. And these domains are linked by an alanine bond. So this is caplacizumab. And thereby, caplacizumab prevents the interaction between the A1 domain of VWF and its receptor on platelets, the GP1B. Caplacizumab has been evaluated through two international trials, first Titan and Hercules. So this refers to the Greek mythology because those trials were huge in terms of logistic organization. And you have here the flowchart of Hercules that randomized 145 patients on one arm of patients treated with placebo and standard treatment versus standard treatment plus caplacizumab. And this is the primary endpoint of both studies, Titan and Hercules. So this is the integrated analysis. And the primary endpoint of these studies was the time to first platelet count recovery. And you can see that patients on caplacizumab arms could reach these primary endpoints, so the studies were positive, as patients recovered platelet count faster in the caplacizumab arms. And you can see more specifically that caplacizumab is efficient in these patients at the very beginning of the management, and especially during the 2 first weeks of the treatment. And this is interesting because if you remember well, this window of time of 2 weeks corresponds to the window during which rituximab is not efficient. Okay, so you have to see caplacizumab and rituximab as two complementary agents that will address two different aspects of TTP pathophysiology. So these two agents are complementary in the management of patients, while one will normalize rapidly and durably platelet count, the other will correct the autoimmune process, which is ongoing in these patients. So both compounds need to be used in conjunction. So these results translate in less unfavorable outcomes in these patients. So you can see that patients in the caplacizumab arms experience much less death, much less refractoriness, and less exacerbations. And impressively, you can see that exacerbations that occurred in up to 35% of patients in the placebo groups were only observed in less than 6% in the caplacizumab arms. So interestingly, you can see that caplacizumab prevents unfavorable outcomes in TTP patients at the acute phase. So on the basis of these results, we could have in France and basically in Europe and then in the United States, the approval for the use of caplacizumab in patients with a clinical diagnosis of autoimmune TTP. So in France, as soon as we could use caplacizumab through an early access program, so this was in September 2018, we organized ourselves to treat patients with autoimmune TTP in France in the same way. So we set up a regimen that we named CAPLAVI, which associate daily plasma exchange, immunosuppression with steroids and rituximab, and caplacizumab. And through an 18 months period, we could enroll in this regimen 90 patients that we compared regarding outcome to historical patients. So you have here the detail of the schedule of this regimen. So in patients with features of thrombotic microangiopathy and a French score suggestive of the diagnosis of TTP, so again, severe thrombocytopenia below 30,000 and a mild renal involvement as defined by a creatinine level below 200 micromole per liter or 2.26 milligram per deciliter, and no associated condition, these patients were treated with daily plasma exchange, steroids, and caplacizumab. And most of us waited for adamantine activity some days later to introduce rituximab. So daily plasma exchange were pursued daily until platelet count recovery, so they were stopped, and caplacizumab was continued until at least a detectable adamantine activity that was measured weekly. And these are the results of this study. You can see that patients in the triplet regimen that received caplacizumab experienced much less unfavorable outcomes at the acute phase as compared to patients in the historical group. You can see that in this study, we had a composite outcome, which a primary outcome that was a composite of death and refractoriness. And you can see that 12% of patients in the historical group reached this outcome, primary outcome, versus 2% only in the triplet regimen. In the same way, we observed much less death, refractoriness, and exacerbations in patients that received caplacizumab. And here again, impressively, you can see that exacerbations that were so frequent in the historical cohort, up to 44% of patients, they were only observed in 3.4% in patients that received caplacizumab. As a result, you can see that this triplet regimen translated in a substantial decrease in the burden of care, as we could decrease by twofold the time to durable platelet count recovery, the number of daily plasma exchange, and the volume of corresponding plasma. And similarly, we could decrease by twofold as well the length of hospitalization. This is a critical slide because it reflects the time to adamantine improvement that shows you when you can stop caplacizumab. So there's some discrepancy in this way, because the SMPC of the agent states that patients should receive at least 30 days of treatment after the last PEX, and then some weeks more if patients still have a suppressed adenosine activity. In France and in some other countries, we started to treat patients with caplacizumab until adenosine is detectable, irrespective of this 30-day duration of treatment. And you can see here in pink those patients that were treated with the triplet regimen, and you can see that 50% of these patients reach 20% of adenosine activity, which is a protective level against TTP at day 28. So in other words, half of patients need at least 4 weeks of treatment after the last PEX until adenosine activity improves. 40% of patients will need more than 20 days of caplacizumab, so 2 months, until adenosine improvement. And 10% of patients, in our experience, will need more than 2 months of daily caplacizumab until adenosine improvement. So this, of course, translates in some concerns regarding cost. So as you can see, we moved now through targeted therapy based in autoimmune TTP. And now the regimen, the standards for the management of TTP are based on the 3 pillars of TTP pathophysiology. So again, you have in this disease severe adenosine deficiency. So you have to supplement these patients with adenosine through daily plasma exchange today, and tomorrow maybe through the use of recombinant adenosine. Immunosuppression through steroids and rituximab mostly, and inhibition of platelet VWF interaction through the use of caplacizumab. So this is a reminder of the ISTH recommendations for the management of patients with TTP when you have a high clinical suspicion of severe adenosine deficiency on the basis of the French score of other clinical scores. So in those patients with a clinical pretest probability which is high, so start plasma exchange, immunosuppression, at least steroids, and strongly consider starting caplacizumab. Then, after some days, according to adenosine activity results, so you will be able to adapt the treatment subsequently. If patients have a confirmation of a severe adenosine deficiency, just continue the treatment, add rituximab if it has not been done. In patients who, in the end, have a detectable or normal adenosine activity, stop caplacizumab and also possibly daily plasma exchange, because this patient may have another disease, another form of thrombotic microangiopathy, typically an HUS. And in those rare patients with a borderline adenosine activity, which have a Grayson result between 10 and 20%, so here it's not so easy. So it's a case-by-case consideration, because some of these patients may still have a TTP. In our experience, some of these patients, but not all, have antibodies against the enzyme. So our use is to use our clinical judgment to guide the treatment simply. So in other words, if the patient has responded to the former regimen, we simply continue this regimen until complete recovery. And this is the scenario on which you have a low or intermediate clinical suspicion of autoimmune TTP, so a pretest probability below typically 90%. So here, the patient may still have a TTP. So given the the fact that it is dangerous to leave a patient with a possible TTP without treatment because this patient is exposed to sudden death, it is wise to start plasma exchange in these patients and wait for adamantine activity. So here again, if in the end and unexpectedly patients have a severe adamantine deficiency, so start caplacizumab and immunosuppression. If, as expected, the patient has a detectable or normal adamantine activity, do not add caplacizumab, of course, and consider specific treatments such as eculizumab if it is an atypical HUS, or treat an associated, formerly not obvious associated condition. And again, in those patients with a borderline result, here again, use your clinical judgment to guide the treatments. So in conclusion, you could appreciate that triplet regimen, which is now the standard of care in these patients, consisting in caplacizumab frontline in association with immunosuppression and plasma exchange, nicely prevents unfavorable outcomes in autoimmune TTP. These targeted therapies based on anti-VWF agents and soon the recombinant adamantine helped and should help in decreasing TTP early mortality and the burden of care. So interestingly, as you could see, these new therapies were derived from a better understanding of TTP pathophysiology, reflecting a shift from empiricism to targeted therapies. And now the perspectives in the management of these patients is to consider more alleviated regimens, especially PEX-free regimens in the future that should be soon evaluated. And protocols are progressively considered and should start very soon. So this is to thank all my colleagues in France on the left and throughout the world for the friendly collaboration on TTP and other forms of thrombotic microangiopathies. And this is a reminder contacting recourse from Sanofi. Thank you for your attention, and I'm open to questions. Thanks again.